This is Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery.
Hi, I'm Jim Denaney, the Executive Vice President and CEO of the American Academy of Otolaryngology, Head and Neck Surgery. I'd like to welcome you to episode 11 of our COVID-19 podcast series. This episode will cover what we may expect as the new normal in otolaryngology practices, both private and academic, and how the COVID-19 pandemic has affected that. I'm pleased to be joined on this episode by three physicians who can speak to various aspects of the topic. First, I'd like to introduce Dr. Joel Selenicchio. Dr. Selenicchio is a pediatrician at Georgetown University Hospital, as well as a technologist, entrepreneur, emergency responder, TED speaker, and medical futurist. I'm also excited to announce that he will be joining us in Boston as our keynote speaker at the opening ceremony in September. I'm also joined by Gene Brown, a partner at Charleston ENT and Allergy Associates, and a member of the board with the OASIS Symposium. Finally, Cecilia Schmalbach, who will represent the academic practices today. Cecilia is the David Myers Professor and Chair of the Department of Otolaryngology, Head and Neck Surgery at the Lewis Katz School of Medicine at Temple University and Director of the Temple Head and Neck Surgery Institute. She's also our coordinator for research and quality of the Academy. Welcome to all of you. What I'd like to do first is thank our listeners, not only for attending this one, but for turning in questions into our website for possible discussion today. Most of the questions that were turned in centered around testing, PPE, and surgical prioritization. This particular podcast was scheduled as a future practice type for otolaryngology, and our next one will feature totally those subjects. The Academy, along with the AFPRS, AOA, ABEA, the AAO-HNS, the ALA, the ANS, AOS, and ARS, who are kindly working with our committees to put together a guiding document for prioritization as we return to office-based procedures as well as surgical procedures, including testing, PPE, and safety measures for staff and patients alike. Our board will be voting on that this weekend, and once we have this out, we will present this in a podcast and get it out to everyone, because I know it's important and how you return to practice working with your hospitals, surgery centers, and even your office staff on how that works. So what I'd like to do is just briefly talk about, we were already in a transition period in otolaryngology of moving to office-based procedures. Over-the-counter hearing aids are going to be coming out in the next few months. Technology was changing, and we'd even started into some telemedicine. So there'd already been a lot of changes going on in practice before the pandemic hit. I'd like now to start with Dr. Selenicchio to tell us some of the things that were already happening and how he thinks the COVID will influence this. Dr. Selenicchio, please.
Thanks a lot for having me on the podcast. This even before the COVID pandemic, it was something that I think about a lot, and I would say that my answers about what COVID is going to mean tend to fit into, for me, a pretty long-term perspective. And when I say long-term, I mean going back decades, going back really to the beginning of the computer revolution, because I think everyone who's on the podcast, whether you're participating as a speaker or whether you're listening, everyone on the podcast has come of age during a period at which one of the processes that's happening within healthcare because of technology is what's often referred to as unbundling. And basically this goes back to the concept that, well, you could really even go back to the printing press and the changes that occurred when the printing press came out. Of course, that was the first time that the general population was able to actually read. They were able to consume expertise, that they were able to consume mass media. But of course, they weren't able to produce it. And I think what's happened over the course, as we get a little bit closer to the modern time, what's happened over the course of our lives is that that's changed even more dramatically, because now with everything from YouTube to blogs to everything else, we've sort of come of age at a time when increasingly mass media is actually produced by what we used to think of as being the consumers. And this is affecting lots of different fields. Famously, it's affecting entertainment, and famously, it's affecting newspapers, where it used to be that it was journalists that wrote the news, and now increasingly it's folks in the general public. Well, of course, it was only a matter of time, I think, before these changes affected those of us who work in medicine as well, because really what we're talking about is looking at the relationship between a physician and a patient, and saying, well, where does the expertise lie? Where does the knowledge lie? And as these technologies have enabled patients, whether it's something as simple as an internet search or the much lamented consultation with Dr. Google, whether it's any of these things, patients have acquired new powers to counter our expertise over the course of the last several decades. And one of the ways, and I know I've talked with some of the folks on the podcast about this before, one of the ways I think physicians don't often think about this, as we think about fancy technologies that are coming up like AI, et cetera. But if you go back and look at even things like over-the-counter medicines, we've seen an acceleration in the provision of over-the-counter medicines, in the designation of previously prescription medicines as over-the-counter over the course of the last couple of decades. And that process that acceleration is made possible by the fact that the population now has access to more resources that used to be monopolized within the healthcare system. And so, again, this is a long-term process. But what we've seen more recently, and especially in the last 2 years, is that we have some new technologies like mobile computing, or really in a way, mobile supercomputing, because any of the phones that any of us have in our pockets are really far surpassing the capabilities of the supercomputers of 10, 20 years ago. And so that's an enormous fact, the fact that everybody's walking around carrying a supercomputer in their pocket that's connected to a worldwide network. And then even more recently, and this really is maybe since 2012, 2013, the resurgence of artificial intelligence, or I should say the collision of artificial intelligence, which is a way to process data and make sense of it, and the collision of that with the fact that we are all generating so much data, whether it's actually the blogs and videos, et cetera, that I mentioned, or just the records of all of our transactions and everything that we do online, and the messages that we send and the emails that we send. So these new technologies like mobile computing and artificial intelligence have really just accelerated the possibility of that unbundling, of that pulling away from healthcare. Just like when you have an over-the-counter medicine, it means you no longer need to go to a doctor to get that medication. It's unbundled that from the healthcare system. Well, these new technologies have done the same. One of my favorite examples is an app and a company called NURX, N-U-R-X, which basically they focus on women's health, and they look at things like prescription birth control. And so they have basically said, well, currently the process for many women is to go into a physician's office, see the physician, go through an interview, physical exam, et cetera, and then get a prescription for birth control. And they said, well, basically you can boil that down to some very simple questions in between the physician and the patient. And they don't actually need to be in the same room at the same time, or even via a video connection at the same time. So what NURX does is, to the consumer, it's to the woman, it's an app that they go in and they answer a few questions. And later at some time, a physician somewhere will review those questions and decide whether they can prescribe medications. From the consumer's perspective, if they do agree to send the birth control pills, they'll simply arrive with no further interaction on the part of the consumer. Again, pulling that one transaction out of the healthcare system. So getting to COVID-19, this process again is accelerated. I mean, certainly no one expected that at this time in 2020, we'd have so many telemedicine visits. But I think it's a mistake to look at telemedicine in particular as being the benefit. I think that as the NURX app for birth control demonstrates, in many cases, there are things that we don't really actually need to be, videoing synchronously at the same time with a physician to do. There are things that we can do at different times. There are things that we won't actually need to be talking to someone and looking at a screen at the same time. So for physicians, and just to wrap it up, I think realizing that this is a decades-long process, we have to think to ourselves, well, what is the role left for us as these things become unbundled? And I think looking at something like Uber is illustrative of the approach that I think we need to take. Because certainly we've seen with Uber that the expertise that was needed to dispatch taxis has become completely automated, completely irrelevant, right? Taxi dispatchers are obsolete. But the expertise that was needed to build and repair vehicles or maintain roads or do all the other aspects of that has certainly not become irrelevant. And the people who do that have not become obsolete, and nor has the expertise to improve those processes and build for the future. So I think when we think about what's going to happen next with all these technologies, with telemedicine, I really don't see everyone's going to be doing a video consultation with their doctor. What I see is that increasingly these processes will be automated, perhaps even surgical processes. But more importantly, what I see as the role of physicians is that we will be the ones who are helping to design and build those cars. We'll be the ones who understand how to deploy those cars and which direction we need to go and what technologies we need to add to the health of the patient. Because again, just as with Uber, that Uber app and the folks at Uber know nothing about cars. They know nothing about building cars. They only know about using them. So for physicians, I think what's reserved for us, again, as we move forward, is going to be the level of expertise, not necessarily to write a prescription, but the level of expertise to decide what prescription needs to be written so that the system will know to do that. If that makes any sense at all.
Thank you very much, Joel. Dr. Brown, would you care to comment on your thoughts in private practice? You're part of a very large network that is extremely well run. I'm very familiar with it. What are the kind of the thought processes that you and your team are going through?
Jim, first I'd like to thank you for having me on the panel. And I would like to applaud your efforts and leadership and the Academy really turning on a light to guide us through the darkness. You've done a lot to help us in an uncertain time, as many of us really haven't been sure what to do. And I'm glad to be a part of that today. I think a local medical personality in our region said recently that the coronavirus is two separate issues. One, there's the biology of the coronavirus and treating it medically, and then there's the psychology of the coronavirus. And as a private practice, as we are taking steps to reopen our doors, we're really taking a long, hard look at the psychology of what this has done and how it's affected our patients and their willingness to re-enter into our offices. And it's really brought the patient completely in the center, and it's allowed us to focus on a lot of patient safety issues. It's led to us changing all of our protocols and all of our procedures that we do in the office. And I think that it's going to be a huge benefit for us in the long term that we've refocused our practice mentality and strategy around the patient. And I think that's probably where it should be. But as was said earlier, this has been an accelerant and has really underscored the importance of that. I think the other things that this pandemic has resulted in for us, and certainly telemedicine and instituting that new technology has been something most of us have done. I think that it's also, at least in my practice, we've implemented other technologies to improve patient communications with texting platforms. And we're really trying to streamline office visits. We're trying to gather more information before the patient's in the office to minimize their time there and they're being in contact with staff and other patients. So it's given us a chance to really rebuild our whole practice with patient safety and trying to instill patient confidence at a higher level than before, because we feel like that's what the public needs to have the confidence to come into the office again. Another effect of this is it's created a time where we could decentralize employees, and we've been able to empower them to do their jobs from home. And I think that'll give some long-lasting benefit in ways to allow employees to more creatively and flexibly work, but also to allow us to not have to have so many physical spaces to house them all. One last thing I want to touch on is it's created, this time of uncertainty has created a lot of virtual peer groups that are exchanging information rapidly online and bringing together peers and colleagues. And I truly think that a lot of these groups will continue to flourish and prosper and help us all to move forward in our practices.
Thank you very much, Gene. Cecilia, I should say Dr. Smallbach. Cecilia, tell me what's going on in Philadelphia in the academic world and what you think is going to be going on in the future.
Sure. Thank you for the opportunity to share and be a part of this wonderful panel. I certainly want to begin by echoing Dr. Brown and Solonikio's thoughts. You know, without a doubt, one of the biggest changes we're actively seeing and will continue to see is the role of telehealth. And so I just want to add a couple more comments. You know, I think for the first time, at least in academic medicine, we really are bringing the hospital to the home, and that's going to provide us a unique opportunity to truly meet our patients literally where they are and serve them. So I think about maybe the mother or father working all day with childcare responsibilities that really does need an evening appointment or a weekend appointment, or we have an aging patient population and it's harder for our patients to break away if they're the primary caregiver during normal business hours. So that platform will certainly open up new opportunities to better serve our community. But it also, when I look at this pandemic, is a wonderful opportunity to leverage, and I think we have a tremendous amount of responsibility to start narrowing the disparity gap. And so I also think about the patient that literally cannot pay for the bus fare to come, you know, to my clinic and be seen in person. I think about folks that can't pay for parking, just don't usually have access to healthcare. Now with appropriate platforms and resources, hopefully we can start reaching out to them and for the first time truly addressing and narrowing that disparity in healthcare that we've talked about for about 20 years. I also, obviously, then you have the whole academic education piece. And when I was pondering that aspect in the post-COVID world, I really thought about training and education in two different pillars, if you will. First, we have the didactic component, and I think we've all become pretty facile now to Zoom. And I think that short-term that has opened up some really unique and wonderful educational opportunities, both to share joint lectures that are interdepartmental at an institution, but also across departments. And I don't think that that's going to be just a short-term change. My hope is certainly that's something long-term. Last week, I had the unique opportunity to be a grand round speaker thanks to Dr. Yarumchuk at Henry Ford, and it was an invitation that came days before. It's one that I wouldn't have been able to say yes to in the past because I would have had to cancel clinic and travel. And so these are some great opportunities that we certainly should continue to leverage. At the same time, as we move post-COVID, and I'm sure you'll touch upon this in the next podcast, you know, we need to think about patient touches, and they'll still be minimal, especially as we await a vaccination. And so when I think about education from the medical student all the way up through the fellow, we need to think about unique opportunities to continue to instill and promote empathy and develop sort of that important patient-doctor relationship that really does come through human contact. And then lastly, there's the surgical aspect of it. You know, the majority of what we do in otolaryngology is elective. Those cases have been put on hold. I think our graduating chiefs are great. By no means should 4 months define a wonderful 5-year curriculum and training. But at the same time, moving forward, the light switch isn't just going to turn back on. And so we need to think about alternative ways for surgical training, leveraging, for example, simulation. And I think there's some wonderful opportunities that come there, especially with respect to patient safety and quality. Along those same lines, I think as educators, the onus will really be on us to utilize milestones and more meaningful feedback so that we can ensure our trainees are getting what they need and leave confident in their skill set. And the last thing that I'll conclude with is, you know, everyone accepts we're not going back to the way healthcare used to be and the way our old system was. And all of us will go through a certain grieving process for how it used to be. And what I would say is when I feel kind of the stress of that, I challenge myself, and I would challenge everyone listening to this podcast to change the lenses that we're wearing. And we have this unique opportunity that we probably will never have again in our lifetime to truly hit the pause button and redefine how we deliver otolaryngology healthcare in 2020, and redefine how we provide otolaryngology education in 2020. If you will, COVID essentially stripped us down and down to the studs. And we have this opportunity to renovate and rebuild. And to me, I actually find that very hopeful and inspiring and exciting. And it's really, you know, thanks to the Academy and the great work you're doing, Jim, that we can dialogue together and learn from one another and really build the best possible platform for otolaryngology care and education coming out of this pandemic.
Thank you very much, Cecilia. One of the things that I think that it's on the mind of many of our members, as technology's gotten better and opportunities to do more things in the outpatient setting have come about, which follows a national trend, moving people out of the hospitals into outpatient settings. How do you see that going forward? Gene and Joel, particularly on the private side, the patients seem to have liked that, just like they're liking the telemedicine visits. But how do you foresee in structuring a practice? You mentioned that you may not need the actual large number of square feet per each facility, but do you foresee being able to continue that trend of doing things in more convenient locations for patients? You think this will help or hurt that?
I'll go first. I think it does help. We certainly have an adjustment period that we're all going to have to work through as patients start becoming more interested in proceeding with elective surgeries. But when we get on the other side of that, I really think that this time period is going to create more opportunity to expand office-based surgical treatment and procedures. I think that some patients are going to leave this time period, and in their mind is a picture of the hospital being where COVID patients are and patients are on ventilators. And I think the office is going to be a more attractive venue to people looking through that lens, where they're going to be more comfortable having a procedure done. Another thing, I think that all of us are improving procedures and processes and focusing on safety and sterility. And I think a lot of these measures and steps we're taking are going to instill a greater consumer confidence going forward, where patients are going to feel more confident that they can get quality treatment, hospital type quality treatment in less formal venues. And then the last thing I'll say is I think that one of the main drivers of office-based treatment has always been low cost. And I think that, you know, the effects on the economy of the pandemic are going to drive more people to be more interested in the lower cost option as well.
Joel, did you have any thoughts on that?
Well, I do think that in the short term, at least, it's absolutely right that the primary, I think, result of the pandemic is going to be cost, and of course, cost is a long-term trend as well, concerning about cost. So, all the reasons why we had, as I say, the unbundling, why all of a sudden having all the services together in a hospital, which may have made sense, economically within the 50s and the 60s and the 70s, no longer seems to make sense for a lot of things. It's easy to open a practice, do a very specialized certain kind of activity in that practice outside of a hospital, and not have to deal with the overhead and all the issues that are involved in having that big bundle of services at the hospital. I'm not sure in terms of what the long-term effects of the pandemic will be, because I hear people saying, well, this is going to change everything. We're not going to shake hands anymore, et cetera. But then we remember that the last time we had anything like this, 100 years ago with the 1918 flu pandemic, that changed, as far as I could tell, nothing at all. So much to the extent that most of us, most people didn't even remember that it happened. We didn't stop shaking hands or seeing the doctor after the 1918 flu epidemic. I'm sure just like now, we did temporarily stop doing those things. But it seems like after a while, we were back to, doing human activities like face-to-face contact with the doctor, and when possible and when affordable, as Dr. Brown was mentioning, when the cost is right, and shaking hands and hugging our kids and all those other things. So in terms of again, I tend to think of the effects of the pandemic, and it's hard to believe this right now, but as really just being a little bit of a bump in the road. It's going to change our national preparedness, I'm sure. It's going to change some of the ways we think, as was mentioned, about safety and security in the hospital from a perspective of sterile practice, et cetera. But I don't actually think it's going to dramatically change the practice of healthcare so much. I really do believe that the things that are changing healthcare are the same things that have been changing healthcare for quite some time, and this may accelerate parts of it and not others. That's sort of how I think about it.
Cecilia, I know you're a head and neck surgeon, for those who aren't aware of that, but it seems like the way ancillary services have been provided, particularly you mentioned the disparity of access and you live in an area of Philadelphia where that's very apparent. It may actually improve the types of care going forward. Could you comment on that, or do you think I'm wrong?
No, I agree. I think that there's tremendous opportunity within academic medicines. We obviously share some of the same challenges that were just highlighted. But to Dr. Brown's point, we do have COVID patients, so we need to start thinking about a COVID clinic, at least temporarily, versus a non-COVID clinic. But when I take two steps back and think about, well, what can be improved, I start thinking about more patient-centered head and neck care, where potentially we could do a lot more of the workup, if you will, up front with thorough chart reviews, getting access to other healthcare providers' records, workup, so that when we do finally have that initial touch with the patient, it will be more in-depth. Maybe it's one step closer to the definitive head and neck treatment. At the same time, we may be able to then bundle together, if you will, some other appointments without it being completely overwhelming to the patient and family. I also think about the fact that our families often are all across the country, and for the first time, we may have the ability through telehealth to bring other family members in that are key stakeholders in the care of their loved one. And I think that will help give improved care, especially when we're talking about difficult decisions of cancer treatment and end of life as well. And then lastly, when we're in academic medicine, we tend to be super subspecialized, which is great, but not always the need of all patients. And so I start thinking about, does this provide an opportunity for my faculty, myself, and my other colleagues to link back into primary care, again, through a telehealth platform, to try and provide a subspecialty opinion or a consult that in the past would have been cumbersome to do, but maybe now we can meet it with this new healthcare technology.
I'm going to shift gears a little bit. One of the things that had been high in the discussion boards and our specialty and others is what were the practice settings going to be like? Venture capitalists were starting to purchase practices. Many had gone to the employed situation. And as a matter of fact, otolaryngology was the second least employed by hospital systems and academics, second to ophthalmology in the whole group. Do you think this particular pandemic is going to change that at all? We've heard many of our colleagues were furloughed or laid off or salaries cut without any say in the matter. And I'll start with you, Gene. Do you think this is going to slow that down or speed it up? And do you think private practice will still be a viable option?
It's a very interesting question. I think that there are a lot of different factors that play into this. I think I want to take a step back first and say most of us still practice in a private practice setting, and many private practices are as strong and healthy today as they ever have been. And I think that's a topic that's not, something that's not stated often enough. But there are a number of administrative burdens on private practices and economic burdens that are furthered by the pandemic. It's going to be more expensive to practice in this new era. The PPE, the different technologies and software that we're going to have to invest in. We're not going to be able to see as many patients. In our practice, we're not going to have a waiting room. People will wait in their cars and we'll text them when to come in. And it's going to create challenges, especially for smaller groups. I can't imagine being in a group where 2 or 3 physicians without a qualified CEO or business head to help navigate these small business loans and to deal with how to manage employment during this time period. It's just a lot. And then rewriting all the processes to come back to work. There are additional strains that this pandemic is gonna impose on us, and I'm afraid that it will lead to more consolidation and more and continued movement towards the corporatization of medicine. There's going to be more safety for younger doctors not having to deal with a lot of these burdens, and it's concerning to me. My heart is in private practice and trying to make that strong in the long run, and it is concerning in that regard.
So I just wanted to ask Dr. Brown, given what he said about the financial pressures that have been brought on by the pandemic, and what we discussed earlier about the kind of absorption or the picking off of private practices by medical corporations or healthcare corporations, do you feel that basically that ENT is now more vulnerable in terms of ENT private practices than it's been before to that kind of absorption?
I think that's a very large concern, and I think it's a great question. And I think what you have is you kind of have a perfect storm where practices are going to have cash flow challenges over the next several months. And you've had this lead in of the last 6 to 12 months where these venture capitalists have been in all of our offices, and they've really targeted larger groups, and they've targeted key individuals who might have a sphere of influence and could be a linchpin to trigger interest in deals with other groups. And this perfect storm of a group being cash flow challenged and venture capitalists with a wad of cash, it's going to be a good out it's going to be perceived as a great out for some practices that otherwise are looking at an uphill fight going forward. And I really think that we might see a lot more venture capital deals over the next 6 to 12 months as we continue to trudge through the pandemic.
It would seem to me with what you've mentioned today on the narrowing margins that the multipliers they're willing to offer are going to have significantly changed after the last 3 months. I can't imagine they won't, but we'll see what happens.
I tell you what, there's double-digit multipliers up to 20, I've heard. being thrown around are, that's hard to walk away from.
Right. I think that that 20 that was mentioned in many circumstances would be a rarity, depending on how much expense is going to rise for that, because someone has to absorb that. So
I would think so. And I would think with our practices being less profitable, which I think they will be, that it would drive down the price. Absolutely.
well, thank you again very much. Joel, do you have any thoughts on that?
Well, it's interesting. I mean, my clinical specialty is pediatrics, and I think in pediatrics, it's much more widespread, of course, to have had private practices consumed by corporations over the course of the last 20 or 30 years. I mean, 30 years ago when I was training, it's much more common to have private practices. Now it's, of course, much less common. And I think that process is just going to continue. I think for otolaryngology, I mean, it's interesting as to whether you sort of see that as somehow unique enough to withstand those processes over the long term, or simply the last holdout, if you will, against those processes. But I think one thing I think those processes started again long before, decades ago, in terms of for a lot of medical specialties. But the things that are new are the kind of advent of the big computer companies, the big information companies like Google and Apple, et cetera, and the technological developments that I mentioned. So, we had talked about this, Jim, before, you and I, about the kind of venture capitalists you're referring to, who in Silicon Valley would be considered sort of the small venture capitalists, folks who want to create a collection of practices or grab practices and consolidate them for efficiency's sake. The big venture capitalists are the ones who want to figure out, is there anything that's being provided by that healthcare system or by that physician practice, that collection of physician practices, that we can pull out of it, like NERCS has pulled out the provision of birth control, any small thing that we can pull out, and then we can make money by charging very little, but providing it to 1 billion people. And that, I think, is going to be a challenge that's in addition to just the corporatization or the big healthcare corporation grabbing healthcare practices or subsuming healthcare practices into it. That's going to be one I think we're going to have to think about a lot more, as initially we kind of ignore it, just like I don't think obstetricians even have ever heard of the company NERCS. I don't think they're thinking of that as a particularly big threat, because they don't make a lot of revenue from giving out birth control pills. But I'm sure the folks at NERCS and the billionaire venture capitalists behind them are thinking, okay, now what else can we pull out of the OB practice? So I think that kind of thinking, and recognizing that some of the most well-funded companies in the world are looking at healthcare, and those healthcare corporations, which, we sort of, you might think of them, if your practice got gobbled up, you might think of them as being the predators, but for Silicon Valley, those are the prey. I think it's going to be interesting to see how that sorts out over the course of the next decade or two.
I've got one last question, and this one I'll start with Cecilia. Part of the success of the treatment going on now during the pandemic has resulted from significant relaxation of regulatory mechanisms by CMS and billing regulations on telehealth, things like that. If these are not continued and they go back to the way they were, do you have any thoughts on how that will affect? I mean, we responded recently to CMS on whether or not residents should be able to you should be able to be paid for supervising residents who are doing a flexible laryngoscopy at a distant site, even though you're looking at them. But a lot of these regulations that are helping patients now, if they go away, it would seem that may lessen the appeal of them. Could you comment on that?
Sure. Certainly that is a concern that has crossed my mind. I'm appreciative that in this circumstance with respect to billing and HIPAA and telehealth, that CMS appropriately and quickly relaxed the policies and regulations so that we could care for our patients. But I think it's a matter of time. This is a platform that we've seen all of our patients embrace, therefore we're going to embrace, and I think that there are going to be future challenges related then to getting appropriately reimbursed. Yet, as we've all talked about on this podcast, that really is our new normal. And to the point I made earlier, that's going to be our new normal platform for training our residents. And so we can't lose sight of that. Certainly regulations are in place for good reason, especially when it comes to various drug approval, drug use, and testing. But it's going to be imperative that we as an academy and various societies partner together to educate and never lose sight of the patient and our trainees as we move forward with those type of CMS and related regulatory platforms.
Well, I'd like to thank all of you for participating in this podcast. I'd like to remind our listeners to continue to visit the COVID-19 resource page at entnet.org and keep up with the latest information from the specialty. And also continue to join the conversation at ENT Connect, where we are sharing information and inspiration and personal stories throughout the pandemic. And now, as always, we are one. Thank you again.
This has been Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery. To download more episodes and our mobile app, please visit our website at entnet.org/frequency. That's FREQUENTCY.